time for Hitting Left with Mike Klonsky and friends on Lumpen Radio.
It's in my walk, it's in my talk. Your woman want me, it's not my fault. I broke some rules, paid some dues, play my blues the Chicago way.
Welcome to the 215th edition of Hitting Left with yours truly, Mike Klonsky, coming at you live today, February 2nd, 2024 on Lumpen Radio, WLPN 105.5 FM, and streaming across the universe at lumpenradio.com. My co-host today is none other than the inimitable Susan Klonsky. Good morning, Susan.
Hi there.
And our producer, well, I'm not sure who, well, I guess it's John Daly, because we had Charlie Garcia in here as well, so we're doubly blessed this morning with a plethora of Lumpen Radio producers. And so
nothing can possibly
good morning.
go wrong.
Good morning, Charlie and John.
Good morning.
Today is a very special day for us, not only because it's Groundhog Day. Did you guys know that? It was Groundhog Day. And not only because Dr. Rachel Rubin is our guest this morning, but did you know that today marks the 7th anniversary of Hitting Left here at Lumpen Radio? Our first episode of Hitting Left with the Klonsky brothers was on February 3rd, 2017. So happy anniversary to us, and thanks to all those like you, John, Charlie, Susan. Let me see. How about Jamie Trecker, our station manager, Stephanie Manriquez, Ed Marzuski, Logan Bay, who was our first producer ever on the show. I'm sure I'm leaving people out.
And thank you for bringing so many voices to the air.
Well, thank you, John.
And don't forget Brother Fred Klonsky.
And Fred Klonsky, my bro, and Susan Klonsky, and several other Klonskys.
Press ganged into service.
We've made it a family affair, and we're happy to continue that tradition this morning. I also want to welcome all new members who have joined more than 1,000 others in our Hitting Left Facebook community and who support the show, and to remind our listeners that they can download all previous editions of Hitting Left at Libsyn or iTunes or wherever you get your podcasts, and subscribe to my blog, don't forget that, on Substack.com, and follow me on Twitter, where I post regularly on everything from Chicago politics to public education transformation to the war in Gaza and so on. My guest this morning, as I said, is Dr. Rachel Rubin. Dr. Rubin is a senior medical officer at Cook County Department of Public Health. She received her medical degree from Rush Medical College and completed her residency at Rush Presbyterian St. Luke's Medical Center.
No, at Cook County.
Go ahead, correct me.
Yeah, no, I completed my residency actually at Cook County Health.
Cook County Health.
Stroger Hospital. It was
it's
before Stroger, yeah.
Somebody got this wrong, Rachel.
Yeah, no, I did a combined residency of
Okay.
internal medicine and occupational medicine, workers' health.
Listen, wherever you did it, we know
Stroger
you're the real
Hospital.
deal.
There you go.
We know you're the real deal, and in fact, you're still practicing internal medicine and women's health.
Right. I practice internal medicine as well at Cook County Health at our core center, where we treat folks with infectious diseases, and I'm a primary care provider for women with HIV.
Okay. John, can you turn me up a little bit here? Also, Dr. Rubin is a long-time Chicago social justice, peace, and people's health advocate. So she is in the mix politically here in Chicago, and it's one of the reasons we wanted to have her on the show today. So welcome to the 7th anniversary episode of Hitting Left, Dr. Rubin. Let's talk about COVID for a minute, more than a minute. Let's talk about COVID. It's been a year since the Biden administration announced that it will have to end its purchase and distribution of COVID supplies as government funding has been depleted. The the U.S. is starting 2014 in its second largest COVID surge
24,
ever.
honey, wake up.
What did I say? Oh, you know what?
Sorry.
2024.
I'm
You
here
know,
to
no,
keep
you know what? I have
honest.
these drops in my eyes. I'm going to have some. What kind of surgery am I having?
It doesn't matter.
I'm having
Let's
some
not
kind of
go
eye
there,
surgery.
please.
In the meantime, I got these drops in my eyes and everything's blurry. I'm trying to. So I saw 2014, but it's 2024, of course, that we're starting, and it is its second largest COVID surge ever. Experts say the United States is in the middle of a wintertime COVID wave driven by holiday gatherings, people spending more time inside. Waning immunity from low uptake on the new COVID vaccine, and a new highly infectious COVID variant, JN1. Did I get that right?
Yes.
Okay. The new fast-spreading variant of COVID-19 is sweeping across the nation, making it the most widely circulating iteration of the virus in the U.S. and around the world, according to the Center of Disease Control. The mutation called, here it is, JN1 is a subvariant of Omicron. Boy, listen to the language I'm using. That was first detected by the World Health Organization in late August. At that time, it appeared to be spreading slowly, but as temperatures have dropped, JN1 has spiked. Dr. Rubin, what is the state of our battle with this new variant here in Cook County and in the Chicago area?
Yeah. First of all, thanks for having me today. It's a pleasure to be here. First of all, the bad news. The bad news is that there's still COVID around and it's with us. It's not gone. This new variant doesn't appear to create more serious illness and symptoms, but any new variant that's coming on that takes hold, that tends to be spreading more than prior ones, is because it's more infectious. It can spread faster, and that's how it survives. Our current vaccines, the good news is that the current vaccines, the latest version that came out this past fall, is effective against this vaccine. And people have to remember that the COVID vaccines do not necessarily prevent you from getting COVID. Just the way the flu vaccines that we take do not necessarily always prevent you from getting influenza, but it prevents most people from getting serious illness and disease, which would land them in the hospital and potentially be fatal or cause long COVID. So the good news is if you get vaccinated, even with this newer variant, you're not going to be getting serious illness in almost all instances. So that's sort of the good news. The bad news is, to go back to that, is that people are not getting vaccinated. The vaccination rate is abysmal. It's better amongst those 65 and older than younger folks. But the overall uptake in our area is about 17-18% of people overall are getting vaccinated. It might be about 40% in the older decades and much lower in the younger. And that's a real problem. You know, there's still these major disinformation going on, the anti-vaxxers saying that it makes you sick. Latest information does seem to be coming out that people that take Paxlovid, which is the medication that you take when you are diagnosed with COVID, and then the vaccines might very well help decrease the likelihood of getting this so-called long COVID, so lingering symptoms and problems that can last months or years.
And what's the disparity in terms of vaccinations in the Black and Latino communities, for example, and with this new influx of migrants into the area? How's that playing out?
Yeah, well, since vaccination rates are so low, it's a little bit hard to parse out, frankly, if there are disparities in vaccines. But if we go back a couple of years when we were sort of in the midst of COVID. One of the main things that all of us in public health were trying to do, especially in Chicago and the suburbs, which is what my department covers, is to make sure that vaccines were available where people lived. So to do what we were calling our hyper-local and local approach towards vaccination, because the Black and Latino populations were highly under-vaccinated, and it's not because they didn't want vaccine, but it's because they couldn't take off from work. They didn't have public transportation. They couldn't leave their communities to go to some clinic, whether it was at, the United Center or a clinic that's nowhere near them. And so we were trying to do hyper-local vaccination clinics. And vaccination now is widely available everywhere because you can get it at a local pharmacy. So there's much less disparity in terms of access. But even so, especially I can tell you in the suburban area, there might not be a Walgreens that's nearby. And we know that in certain communities in the Southland also, that there aren't CVS's or Walgreens nearby, or they have run out of their supply of vaccine. Early on, when this newer vaccine came on in the fall, you had to go online to make an appointment, so you had to know how to negotiate that. Or if you went in as a walk-in, you would have to wait, and then frequently they were out of their supply. Now supply is really not an issue. And luckily, even though the federal government is no longer providing free vaccines, which I think is a real problem, that we should be giving vaccines for everything, for everybody, for free. But now everything is commercialized. So if you have insurance, it will be covered. And that's Medicare, Medicaid, or private insurance. If you don't have insurance, like you're a new arrival, these asylum seekers that are coming in, you can go and you can get a free vaccine because there is a federal program that's called the Bridge Program that covers you if you don't have any insurance. Also, if your insurance, especially private insurance, has big copays for the vaccines, there's now a program where you can get a voucher. Actually, the voucher is for Paxlovid, but also that you should be able to get these vaccines for free through your insurance one way or the other. And then Paxlovid, if your insurance doesn't cover or you have high copays, there's now a voucher system. But you have to know how to negotiate all these systems.
And you have to be able to presumably speak English, not be worried that you're going to get grabbed by ICE or
Of
something
course.
bad will happen to your family if you show up at a public space.
That-
And so
absolutely.
how do people find out this information, and what's the role of the county health system in getting the word out?
Yeah, no, we're trying to get the word out as best we can through social media outlets, in Spanish at least, as well as English. One thing about the asylum seekers and new arrivals, when they come into the shelters now, originally 2 years ago when they first started coming, year and a half, every single one of them was sent to the Belmont Craig and Cook County Health clinic, and they would get all the vaccines that they needed if they didn't have them already. But then as we started to get flooded with more and more arrivals, the county system couldn't keep up in terms of screening every single person. So they now, just over the last month, have mobilized mobile teams that are now going into all of the shelters, and they are doing triage now of everybody.
What does that mean?
And what triage means is that if they see somebody that is seriously ill that needs immediate medical attention, they will get them to the hospital. If they need to be seen in the clinic quickly, whether it's a child that needs to have an exam so that they can start school, or whether it's an adult that has a medical issue that needs urgent attention, they are then given an appointment as well as transportation to get to the Belmont Cragen Clinic. We give them all the vaccines that they need at these clinics. They can also go into another Cook County clinic and get a vaccine. So this information is being given to people that are in the shelters. But more and more of the arrivals are either not going through the shelter system, they're not coming to the landing zone, or they are, but then they don't stay.
Well, you
Understandably,
can't really blame them.
I don't blame them. Of course not. Of course not. The housing in the shelters is really very, very difficult.
And there's a threat of them being kicked out of the shelters after 90 days now.
Well, the mayor keeps pushing out that date. Now I think it's March 1st, and I can't really speak directly about all of the systems in the city system for dealing with the new arrivals. But what I read and hear is that, he keeps pushing that date out. But we need to have enough beds. And I've heard that one of these shelters, there's maybe 18 inches between the cots. It's just one row after another after another.
And so the conditions for spreading not just COVID, but all kind of viruses and infections is very great.
That's right.
And this is a question I wanted to ask you. How high is the COVID risk currently in Cook County, say, as compared to nationally and globally? I mean, what's happening in a macro sense?
Yeah, I mean, when I checked just a few days ago, 2 weeks ago we were in moderate community transmission. We had gone from low to moderate, and now we're back down to low. So if we keep our fingers crossed, maybe this particular surge over this past winter has peaked and will begin to go down. And what's an indication of that, too, is that we look at wastewater levels of COVID and influenza and a couple other things. And the COVID levels in wastewater had been going up and up and up, even though the number of hospital admissions were fairly stable. But now wastewater at least has begun to channel down over the last week or two. So hopefully, at least in the Midwest area and locally in the Chicagoland area, it certainly won't be getting worse. Sometimes there can be ups and downs throughout the peak season. And even with this new variant, I think that's the one thing that's worrisome, is that you have this new variant. Does this mean we're going to have another peak?
Especially if the weather gets colder. We've had a pretty mild winter, except for maybe one.
I don't know if the cold weather in and of itself makes a difference, because we haven't quite yet seen a seasonality to COVID. Even though the highest peak seems to be in the winter, we also have had a peak in the late spring, in the late summer. We've had other kinds of surges. The virus is still sort of equilibrating, so to speak, in our ecosystem. And eventually, we imagine that it will be seasonal and likely to be peaking in the winter and not seeing sort of these other sort of surges. But I wouldn't be surprised if we settle down now and we have a little surge again, maybe in the spring.
So one question I have, I noticed that at the University of Chicago hospitals, all personnel are having to wear masks again now to prevent or to reduce transmission. And what's Stroger doing, and what about the folks in the jail and in the jail hospital? I know the hospital isn't your jurisdiction, but how is it being dealt with?
Yeah, well, Stroger Hospital has mandated masks for everybody, patients as well as personnel, in waiting rooms as well as all patient care areas. And that has been now for several weeks. It's not something that was just instituted.
It's good to hear. And so I understand that you played a significant role in the recent decision of the American Public Health Association. To get political here for a minute, tell us about this, and how is it an issue that the American Public Health Association adopted a resolution in favor of a ceasefire in Gaza?
Yeah, well, I mean, I can say that everything is public health. Right?
Thank you. I'm right there with you.
And I've been a member of the Public Health Association for about 30 years, and since I was a student and a public health student. And the conditions in the Middle East, in Gaza and the West Bank and the occupied territories, have been horrible for decades now in terms of the health conditions of the population, of the Palestinian population. So through the American Public Health Association, it's not the, as well as many other areas, is that we established maybe 10 years ago or so what we call ourselves the Palestine Health Justice Working Group within the organization under the International Health section of the organization. The organization is divided up into different interest sections. My main section is actually occupational health and safety because I'm an occupational medicine physician, and also international health. And so this working group, what we've done and what we have tried to do over the last 10 years or so is pass a resolution in support of improving health for the Palestinian population, which means ending the occupation. That's the number one thing that has to happen. If you're under occupation or if there's a blockade like there is around Gaza, there isn't appropriate access to the first world medicine that they have in Israel proper, which is highly sophisticated, and they have everything there. And the living conditions in the occupied territories in Gaza have not been good as well for decades in terms of water quality, for example. In the West Bank, settlers have been contaminating the fresh water supplies that go to Gaza, to West Bank residents, and the amount of water that is piped in from Israel, from the aquifers or wherever it comes from, is limited. It's rationed about how much can go into the West Bank. It's much less than what the Israeli population have in Israel proper. And Gaza, of course, their water source, they're right on the ocean. They have a big desalination plant to remove the salt from the water because you can't drink salty water. It's fatal after a period of time. And so then we have this war that's going on that started October 7th. And so
not good for people's health.
Not good for people's health. And so the Health Justice Working Group, the Palestine Health Justice Working Group, we have been unsuccessful in getting any sort of policy passed in support of improving Palestinian health. There were two or three attempts, and it was voted down by the governing council because of pushback from Zionists that's saying you're neglecting the health of Israelis, but the Israeli health system is very robust. And there were many other, it was obviously always political. So we thought we have to try again. We have to get the American Public Health Association, the largest association of public health professionals in the country, to take a stand. And this was in early November. So this isn't now where now everybody's saying, okay, we should have a ceasefire. Not everybody, but many organizations. This was early on. This was in early November. And so we wrote an 11-page late breaker policy because that's the process. You have to do a late breaker because it was after all the other policies had been submitted that would be reviewed at the national meeting in November. So we wrote an 11-page policy. It went through appropriate review. Long story short, it comes to the Governing Council Board debate. And we had a very contentious debate. Debate is usually like 20 minutes, and then you're 15 minutes, and then you have to ask for an extension. It went on for an hour and a half. And it was clear that there was a lot of opposition to it, but there was also a lot of support. There were a lot of young public health professionals that came out for our working group and stood in the back of the governing council silently and respectfully during the debate to show that there was major support in the organization. And so a recess was taken after an hour and a half, and we rewrote this 11-page policy into one sentence. One sentence. And that passed 90% for it. And what the sentence said is that the American Public Health Association calls for an immediate ceasefire in Gaza and the provision of humanitarian support to sustain appropriate life within the Gazan territory.
Well, of course, it's not just Gaza either. I mean, what's the, why are we even talking about Gaza in terms of public health in Cook County and in Chicago. I mean, what's there's a connection, isn't there? I mean, between war in general and the health conditions globally. I mean, soldiers come back home. The rates of suicide are tremendous. I think even in Gaza, there's such a high percentage of people dying from disease. I don't know how it compares to those dying from being bombed or shot, but I'm sure it's close. And that was true in the war in Iraq as well. So it seems to me that doctors, that physicians, medical workers like yourself are generally anti-war. They know that war is not good for public health.
That's right. War is not good for living things. Remember, there was that old T-shirt, right? That old saying, right? No, that's absolutely correct.
But how do we make that connection to the American public?
Well, it's what's happening especially in Gaza is that the population is also being displaced, which is a major consequence of war, and it happens in other wars also. But it's a very small territory, and they're being pushed into a smaller and smaller space. They're living in these outdoor sort of tent enclaves, camps that have been set up by the UN. And people are living very close together like sardines, which means that more people are going to be getting sick and dying from disease than, the 26,000 that have already been killed, civilians that have already been slaughtered. So there's already, we know, a spread of communicable diseases going on right now, diarrheal diseases, especially amongst kids, children who are much more vulnerable to that. There's the lack of clean water. There's going to be massive starvation. They're really on the brink of famine right now. There's already starvation, but it's really on the brink of famine. And so these are all consequences of war. And absolutely, there is a peace caucus at the American Public Health Association that specifically focuses on the health consequences of war. And this is another example of that. And I do think that it is the duty of all medical and healthcare providers, not only those that give direct care, but all of the incredible public health workers that bring in aid. And as public health, we make connections to housing conditions, food, water, mental health. These are all, underlying social determinants of health, we say. But we have to look at what we call the structural determinants. What's underlying this? That's what we really have to be attacking. And I think as health professionals, it's our duty. I think it's part of our oath and our obligation to fight against war and to fight against oppression wherever it is.
If we were having this discussion in the, let's say 70, 80 years ago, we might just well be talking about the Warsaw Ghetto. With all the conditions that you've described, just bring back thoughts of everything I've read about what conditions were like. And that surely, it amazes me that American Jewish people, like ourselves, can't get that connection.
Yeah, it's sort of like the Holocaust has its own separate niche, that's not really quite the word, but its own sort of separate significance. There have been Holocausts throughout millennia, right, throughout history. And maybe what we call the Holocaust in Europe was one of the worst, and it was certainly an attempt to annihilate a people, the Jewish people, at least the European Jewish population. And that's what's happening now. Don't tell me that what's happening in Gaza and also in the West Bank is not meant to destroy a population, to eliminate a population. And there are some Israelis that are saying that. And for Jews to not make that connection, I think is a real problem. I mean, something that happened to me that is telling is that at the American Public Health Association, after the debate was over and we won, and it was a compromise, but it was still a great moment. Afterwards, we're all sort of very happy. A woman comes up to me, and she says, "I'd like to talk to you." And I said, "Sure." And I didn't know who she was. And we both had masks on. We couldn't really see each other's faces very well. And she said, "Are you Jewish?" And I said, "Yes." And she said, "Do you have family that died in the Holocaust?" I said, "Yes." And she said, "They're ashamed of you now. They would be ashamed of you now." And then she started to get,
Ouch. Yeah.
yeah, right. And I'm like, no, they wouldn't be ashamed of me now. And I'm the descendant of generation after generation of rabbis. My grandfather was a rabbi, as were some of his brothers and his father and that father and that father and that father. I bet that my grandfather, he would not be supporting what's happening right now. He would say, as a Jew, we have to fight the oppression of another people and the annihilation of another people, and this is a genocide.
We are talking
Thank
to
you.
Dr. Rachel Rubin. Wow, you left me,
Sorry, I
other-
got riled up.
No,
here.
no, that's good. I want to continue this conversation after our break. We're going to break for a couple minutes, and then we're going to come back with Dr. Rubin, and we're going to talk more about the politics of health, COVID, and where we go from here. So stick with us.
Let us be together tonight. Don't let us get sick.
Welcome back to Hitting Left, the 215th episode of Hitting Left, by the way. This is our 7th anniversary of the Hitting Left show. Welcome back to our guest, Rachel Rubin, and Susan Klonsky and I are co-hosting today, John Daly at the controls. Dr. Rubin, before the break, we were talking kind of about the global politics of healthcare and disease. Let's get back to Cook County for a minute. You are a medical professional, but you're also a political creature by necessity. I mean, you're working for at the pleasure of a political organization. The Cook County board president is also the head of the Cook County Democratic Party, and we are in a city that's going to be the host of the Chicago Democratic Convention this year. Some of us who go back a ways in time remember the 1968 Democratic Convention, where we turned the city upside down, fighting against war in Vietnam and against other social issues, and that was also an election year, and the protesters, me included, were kind of blamed in a way for the defeat of the Democrats that year when Humphrey lost to Nixon. Humphrey was the war candidate, and the Democratic Party was the war party. And I'm thinking that 2024 has a lot of similarities to that period. So those of us who really are anti-Trump and can't imagine another 4 years of Trump, how do we take on the White House and current administration's policies, and at the same time try to defeat Trump and the Republicans in 24? You got any thoughts about that?
Wow.
And I'm speaking specifically of health issues, and because as you know, Cook County can't fight these battles itself, and neither can the city of Chicago. We need to have support from around the fight against COVID and other things. So how do we navigate those waters?
Yeah, well, we need a major change and shift in health policy on a federal level. I don't see that coming from either Trump or, frankly, Biden. But I certainly think that we can try to, push the envelope and continue to advocate for, first of all, single payer. We need to have a single payer healthcare system.
Who's talking about now that Bernie Sanders isn't running? Where is that voice?
Yeah. I mean, Bernie is still trying to pass a kind of a single payer system, but it's, You have to understand, who are our elected officials, are our politicians? They're capitalists. The idea is that they're not going to nationalize the healthcare system, which is frankly what I think is necessary. And single payer is not doing that. That's sort of halfway there. What single payer is doing is or as people say, like Medicare for all, it means that it turns, at least at a minimum, it turns healthcare as a right into a right instead of a privilege in this country. And it means that everybody has the right to decent and equitable and access to the right kind of care that they need, medical care, and also preventive services, obviously. And so that's one battle that needs to be continued. And there are many organizations, not only Physicians for National Health Program, which I'm a member of, but there are many, many other formations all over the country that have been fighting for single payer for decades now. And I think that we have gotten, even with the so-called Obamacare, the ACA, Affordable Care Act, did expand at least Medicaid expansion in most of the states. And to maintain and not to lose that, we at least have to fight to not lose that Medicaid expansion. And then there's also the public health. I could go on and on about single payer, but then there's also public health. And what public health, the distinction I see sort of between public health and what we call sort of population health, which is sort of more clinically oriented. Population health is where you try to focus on decreasing stroke and heart disease and diabetes. So doing those things that people can exercise and can have access to healthy foods, that kind of thing, which is very, very important. But I think what public health does that, tries to advocate for that, but it's also trying to look at the underlying conditions that people are in that produce poor health outcomes. So living in communities that don't have sidewalks, so people can't walk. They have to have a car. So there is no place to exercise or move around. Living in communities that are not safe, they're dangerous, so people are afraid to go out their front doors, much less that there is a park nearby where they can go to. It also means looking at the access to food and the food deserts that we have throughout many of our communities. It also means looking at housing and looking at the unhoused and getting them the help that they need so that they can remain housed, not only finding the housing, but also the supports, the social supports that are needed.
We've actually got 2 suburbs of Chicago right now on the south side where the water is undrinkable. And people are under boil orders, and a lot of people don't have access to tap water at all until this problem gets repaired, and it's dragged on for a couple weeks now. And others where the lead contamination is high enough to be compared to Flint, where the problem has never really been solved.
I think
it's
Jackson,
amazing.
Mississippi is also in that situation.
Yes.
Yeah.
And this is 2024 in Chicago, where we've had a public water sanitation system for more than 100 years. But it boggles the mind.
Yeah, it does. And like what's happening in Dixmoor, for example, with the water, it's because the pipes are old and they need to be replaced. The mains need to be replaced. And also, I don't know if people are aware, but that the suburbs have to purchase their water from the city. We have water bills and we pay, and our water bills have gone up. I remember until just a few years ago, the water bills were really fairly low, and now they've gone up in the city of Chicago. But in these suburbs, they have to purchase the water from Chicago or purchase water that might be piped into a neighboring community, and then they share that. And that's the situation out there in the south suburbs. And places like Dixmoor, they're very poor, and they don't have the money. They don't have the tax base in order to replace these pipes. And so what happens is that they have to go into these boil orders, and then bottled water is brought in for people to have to drink and to cook with. But then you also have all the plastic. You have all of this stuff, right? And so it's horrendous. And for this to be happening in the United States and happening, next to neighborhoods that have no problems.
In a way, it's a microcosm of Gaza. The politics of water and the control of water and the connections with public health, et cetera. But you were talking about public health, and it seems to me that right now one of the battles is to keep the word public in everything, in public education and public health, and that
public libraries,
public libraries, and that the real political battle right now, in which we are right on the strategic defensive now. It's not like several years ago when we were actually fighting for a public health system. Now we're just trying to hang on and keep every little vestige of public health from being taken away. Entitlements, women's health. Now that the Supreme Court, after the Supreme Court ruling, this defensive battle is what's happening now, and we see the rise of a MAGA movement that's an anti-taxer, an anti-taxers and
anti-vaxxers.
Yeah. I see that. I see there's an attack now on Taylor Swift. Have you been following that? The right wing is attacking Taylor Swift and her boyfriend Travis Kelce, the great football player for the Kansas City Chiefs, because Kelce has been doing ads for vaccination, for calling on people to get vaxxed, and he also does Bud Light commercial, which has infuriated the MAGA movement, and so this is being played out in terms of public and mass culture as well, and so the danger is incredible, and that's why I'm really asking you about the connection between the local situation here. We don't really have a right-wing MAGA movement as in much of the country, but still the politics of health are impacted, by this culture war. So your thoughts on that?
Yeah, no, clearly it's being impacted.
The fight over the resolution of the city council here last week is a good example. Right.
No,
Here
exactly.
in Chicago.
Here in Chicago.
In the city itself. Yeah, I mean, people are becoming more and more polarized.
Yeah.
And that's very scary, right? It sounds, there's like no room for consensus. I don't even want to say compromise, but there's no room for consensus where people sit around a table and they decide, a progressive policy that would benefit the people. I'm willing to pay more taxes if it means that I get free medical care. I don't mind doing that. It's and this happens nationally, but also on the local level. I think that the convention probably provides an opportunity, and it means being out there in the streets, but it also means even before then reaching out to our, in the state of Illinois, our delegates to the Democratic Convention are basically our politicians, our elected officials. They're the ones that are delegates. There are very few that are not. They're the same. And the idea is to begin to lobby them on these issues now, to maintain funding and to support public health. And this should be pushed all the way up to the state and to the federal government. The federal government shouldn't be pulling back on public health funding, whether it's for the CDC or whether it's money that is pushed out to the state health departments and then the local health departments. We got a lot of influx of public health money to support our public health departments, as well as organizations that are doing public health even when they may not call it public health. An organization that helps the unhoused, an organization that has food banks, the Chicago Food Depository. These are public health organizations, and they were getting support, government funding support, and that's all being pulled back now.
And the GOP has tied funding even for something so simple as the home test kits for COVID to sealing the border and preventing immigrants from
Right,
coming into the
right.
country. So public health, in a very real way, is being held hostage by the Republican Party, seems to me.
In a way, the culture wars have won. The culture warriors have won on the issue of masking. Susan and I just flew back from California, and I swear we were the only ones at LAX who were wearing masks. Maybe one other person out of the 100 or so that we would pass, or
Only our fellow geriatrics.
And I think it's because people don't want to be. Well, maybe it's just inconvenience, and they're not really worried about this new upsurge in COVID or what have you. But I think the politics of COVID play a role in this.
Well, I think that they do. I think that people are getting, we call it COVID fatigue. They're getting tired. They have already gotten tired of the regulations. There was so much pushback when my name would be on these orders, for restaurants, that they have to check vaccination status before they let you in, for example. People are tired of that. And there isn't the political will anymore, for example, to put in mask mandates, to say that in large gatherings that you have to wear a mask, that in a public concert that you have to have masks on, for example. There is no political will to do that anymore. There has been just way too much pushback. So that is, so what we consider good public health is indeed being affected by the politics. It's not just funding, it's also policy that isn't necessarily tied to specific funding. And I think this is something that we can affect. But, there's, as we say, the other side has the money, But now with all of this disinformation out there, it's constantly fighting against that and debunking again and again and again, the stories about that masking doesn't make any difference, that's not the problem. But it does make a difference, and it has been shown in well-controlled studies that it does make a difference, just as an example. But, I know you're asking sort of a bigger question, and I'm not quite sure.
Well, let me ask you a simpler one. Who coming up as a professional in medicine, who are your heroes? Who are the people that you looked up to and that kind of tried to model your career on?
Well, in terms of those that have passed, certainly Quentin Young. In fact, talking about Quentin, the last time the Democratic Convention was in Chicago, and it was at the United Center.
1996.
I was on the picket line with Quentin. We happened to choose the same time slot to be there, where they sort of cordoned us off behind these sort of barriers so that the delegates going into the convention could sort of see us from a distance. I was on the line with Quentin, and I knew him for many years.
He was a fierce advocate for public health care.
For public health, single payer. He had been at Cook County before my time, but just before, as the department chair of internal medicine. So he certainly was one of my heroes. In terms of living heroes, Dr. Linda Murray, who is a close friend, but she also has been a mentor of mine, also trained in occupational medicine like me, and internal medicine. There are all kinds of sort of, heroes out there, but I'm trying to think sort of within the health sphere.
I've been very moved and impressed by those doctors from the Chicago area who in recent weeks have gone and volunteered in Gaza under unbelievable conditions, terrifying conditions.
Right,
using
Med Global.
their-
Right, Med Global is the organization
Yeah,
that some of
it's
them have
astonishing.
come from.
And Doctors Without Borders, too. I think.
Doctors Without Borders, the Palestine Children's Relief Fund folks. One of the physicians, he's a pediatrician who I knew from Cook County, John Kaler, who is one of the doctors that I think has just returned from Gaza. And he's a retired pediatrician. And to go there, I went and worked overseas for a couple of years. From 1990 to 92, I was in Mozambique, and that was at the tail end of the war there. But I didn't necessarily feel unsafe. It was nothing like going to a war zone where a bomb could drop on you at any moment. kudos to those colleagues and folks out there, because of course they're my heroes. Of course.
Forbes has an article, I think it's today or yesterday. They say that healthcare ranked as a key issue for over 60% of voters in the 2022 midterm election, according to Pew Research. And the healthcare policy issues on that ballot undoubtedly shaped numerous races. The U.S. spends more per capita on healthcare than any other developed country, while achieving poor outcomes when measuring life expectancy and maternal and infant mortality rates. Forecasters should expect what Forbes called a rhyming outcome in 2024, the presidential race, as many of the same healthcare issues that influence the midterms remain at the forefront of voters' minds. But I'm thinking that when I hear the campaign speeches from the Democrats and Republicans, I don't hear these issues being talked about.
It's not on the radar now. I mean, now that people think COVID is past, which it is, beyond us, which it is obviously not. It's not an issue now. It's not an issue. And to your point about how the U.S. does spend per capita, what are they spending the money on? What are they spending this money on? I mean, some of it is certainly supporting the Medicare program and Medicaid. But
which is under attack.
Which is now under attack, right, that they want to privatize that. I cannot stand. I have patients that are on Medicaid, for example, but it's Medicaid managed care. It's the private insurance companies that are now taking over the public insurance plans. And it is then much, much harder for me to take care of my patients.
So,
and that's certainly the case for us in Illinois.
Yep.
Yeah. So, I know you don't know where this is going, and neither do I. It's hard to make predictions because everything is so unstable. But reproductive rights issues comes to mind. I mean, that's certainly a dividing point between Democrats and Republicans. We're not looking for consensus on that. We're looking for a battle. We gotta win those rights back for women. I'm remembering when Trump got elected in 2016. The very next day, there was 1 million people in the streets, led by women's movement, raising these demands. But I don't know where that is right now.
Well, what's very interesting is, of course, reproductive rights and the end for a woman to be able to control her body, is horrible. And Illinois, we are now providing abortion services to residents of Wisconsin and Indiana and other states that have Missouri, yeah, right? And so Illinois, we're sort of in the Midwest, we're sort of the savior for the surrounding states, and we are continuing to do that. And luckily, we have a governor now currently that is very supportive of that. But what's interesting is, I don't know if you heard what happened in Tennessee a couple of days ago. One of the I think it's a state senator who is Republican, who had voted to restrict abortion in Tennessee, is running for re-election, and he is now reversing his stance on that. At least for women that are, it's not reversing completely for abortion, but to at least allow the exception for when the child is not likely to survive or the woman's health is in danger. To me, that's just, a minimal change. But here is somebody who is saying under no circumstances does he support abortion. The problem is that OB-GYNs now are afraid to do even what are called therapeutic abortions, which means when the mother's life is in danger or there's been fetal demise, the fetus has died, and then they're making you take the child, the fetus to term and then deliver at that time and then go through labor. And that can be also not only obviously, as you can imagine, emotionally horrible for the woman, mental health-wise, but also it could be a danger to her. And so OB-GYNs in these states are afraid to do what is considered standard medical care. And so this Tennessee senator at least is backing off on that bit of it. I think that this is going to make more women vote against Trump.
From your lips to God's ears.
Well,
Let's hope so.
I hope it's significant enough.
We're going to have to close on that note, on that optimistic note. I hope you're right.
I don't know.
Thank you, Dr. Rachel Rubin, for being a guest on our show today. Thank you to our producer, John Daly, Susan Klonsky, for being co-host today. Don't forget to join us next week. We're going to be talking with some anti-war activists around the issues of Gaza and the potential war in the Middle East and Ukraine and places like that. And we're going to keep fighting for public health. So join us next week.